Good afternoon, everyone. Please take your seats or get refreshments and take your seats. Thanks for joining us here today in person. It's great to see so many people we've been working with on these issues for quite a while now, face to face. And also a special thanks to everyone who's joining us virtually today. We have an audience from all across the state and a number of people from elsewhere as well. We want to hear from all of you as part of this meeting on this very timely topic of launching the North Carolina State Transformation Collaborative. This is an initiative that you're going to hear more about now. It's been quite a while in the making, but before I start on that, I want to give a special thanks to many of the leaders from diverse parts of the state and diverse perspectives on improving health and healthcare who are joining us today. That includes leaders from the Center for Medicare and Medicaid Services and the North Carolina Department of Health and Human Services. People have some very busy schedules with a lot going on right now, as well as the many private sector leaders and leaders from associations across the state, many of whom you'll be hearing from in the next few minutes. Also, a special thanks to the Healthcare Payment Learning and Action Network. That's a mouthful, but it's a public-private collaboration aiming to bring different perspectives together to help us accelerate progress. Again, the main topic here today in North Carolina. Before we get going, I'd like to make sure we know a little bit more about everybody who's joining us today. If you look up on the screen here, on your screen virtually, if you're joining us, there is a QR code that you can use to connect to a Slido poll, which will give some options for you for describing who you are and where you're from. So while people are putting in their responses to that, I'd like to just say a little bit more about the State Transformation Collaborative, which is, again, a public-private partnership. It's operated by the Healthcare Payment Learning and Action Network and supported by the U.S. Centers for Medicare and Medicaid Services. This is a kind of unique partnership that reflects something that all of you who are concerned about the future of health and healthcare in this country know, and that's that we need to work together. This is a big and complex healthcare system, and it involves a lot of perspectives that matter, in particular around some shared goals of enhancing patient experience, improving population health, which has been sliding the wrong way during the pandemic, as well as before and now after we're out of the acute part of the pandemic, making healthcare more affordable, and reducing the administrative demands on healthcare providers, all while advancing health equity. So that's a complex set of goals, and you can see why it's so important to try to come together to address them. This particular effort has been a while in the making. At Duke-Margolis, this is our 6th year as a university-wide center at Duke. We rely a lot on bringing together different perspectives to help guide effective development of solutions and analyses on important and challenging policy issues and supporting healthcare reform. We've done a lot of work here in the state on issues like expanding access to insurance coverage effectively, facilitating COVID-19 response and coordination of activities around diminishing the burden of COVID and helping make sure people get accurate, timely, actionable information and support in taking steps to address COVID, and many other efforts related to transforming healthcare to make it more oriented towards a whole person, more prevention-oriented, more coordinated, more affordable, more equitable. So North Carolina is a state that is a great place to do this because it has such a strong history of collaboration. People may have different political views, different backgrounds, somewhat different priorities, but can all come together. So a great foundation to build on here. And we've seen the efforts to get progress on healthcare transformation happen both through private sector perspectives coming together and through efforts by the state government. The legislature has been involved in bipartisan support for Medicaid reform, and the Division of Health Benefits, the North Carolina Department of Health and Human Services, as a quality strategy for Medicaid transformation that draws on experiences here from input from many of you and from experiences around the country. The Division of Health Benefits has already implemented a number of steps around multi-stakeholder alignment here in North Carolina, including some of the priorities we'll talk about today: minimizing administrative burdens for providers, enabling health plans to innovate, focusing on results that matter. And the states recognize that this happens best through partnerships that reflect input and ideas on how to work together to succeed in paying for better health and making progress on improving health and health equity through an up-to-date Medicaid program. But we also know that it's not just about Medicaid, right? These are system-wide issues of reducing administrative burdens on providers as we change payment systems and try to get more value, better results out of our healthcare system, better sharing of data, better collaborations around new care models. And the North Carolina State Transformation Collaborative is an important mechanism for engaging all of these perspectives together, all of you who have a stake in these issues. And I know so many of you have cared deeply about it, devoted your careers to improving these goals around health and well-being of North Carolinians. And all of that is what the State Transformation Collaborative is about. It's also intended to be a model for other states around the country and to draw on innovative experiences that other states are finding and learnings that they have as they take on these similar kinds of issues. I also want to thank Arnold Ventures. They've supported our work around the development of a framework for best practices and experiences to bring together efforts, bring together different stakeholders to accelerate progress on care coordinations, outcome, affordability, and equity. And I think we have a framework. I'm not sure if the slides are up about that. And maybe I can go back now to the results of the Slido too, if we've got those up. So diverse set of perspectives here, other being the biggest category. Like those who are other, what's an other? But besides that, it's great to see a range of academic perspectives, healthcare providers, health plans, students. Thank you all for joining too. A lot of different perspectives here today, which is exactly what the State Transformation Collaborative is intended to support. So thanks for all those perspectives. And as I said, we're trying to draw on experiences in the state already about bringing different stakeholders together for common action and drawing on national experience and our research supported by Arnold Ventures. I think that may be the next slide, Johan. Okay, well, let's keep going. Okay, stakeholder groups should also a couple of other background points when we talk about alignment, as I've just been doing. This is about applying evidence, not about taking steps that are anti-competitive. You'll hear us reference throughout the day multi-payer, multi-stakeholder alignment efforts. This means developing and applying evidence and assessing what approaches where common standards can help to get to better outcomes and lower costs. This is not about agreements on issues that could impede competition, quite the opposite. The explicit goal is to improve data sharing, improve information on competition and care. I think on the next slide, our agenda. So we've got a lot to cover today, and let's try to move through my remarks quickly so we can get to it. We're going to talk about a vision for the North Carolina State Transformation Collaborative. We're going to talk about how the STC can have an impact on national reforms, and we're very pleased to have the national perspectives from CMS as part of that. We'll talk a lot of the time today about, okay, we have these concepts in mind, these goals in mind. What are we actually going to do to make progress on these steps? So start thinking about that now, as we're going to try to identify some common ground, some common approaches where in 3 or 4 major areas where we're aiming for transformation, where we can make progress more quickly. Let me see any other slides that I need to use before going to Cody. No. So let me just go back and make one more comment about building on this strong foundation we have to work together here. You're going to hear from Dr. Whitaker about 4 areas where we've heard from many of you who think that progress is possible. So again, We want to turn this general commitment and foundations we have working together into opportunities for more specific progress. And so with that, I'd like to introduce our next speaker, so we're going to be joined by Secretary Kinsley, but he is not quite here yet. So our next speaker up is Kate Davidson. Kate, I've had the pleasure of working with in her leadership position at CMS on finding ways to accelerate progress nationally. Kate leads a team at the Center for Medicare and Medicaid Innovation, the Innovation Center at CMS, that's focused on accelerating health system transformation. That includes leveraging the science of care improvement within and across the different payment models that CMMI is helping to develop and implement nationally. It also includes learning from a lot of experiences around the country, like what we're doing here. Kate comes from a background prior to government service in developing and implementing innovative care models to address mental health and substance abuse issues, also something that's very important here for North Carolina priorities. So Kate's going to talk about the role of the state transformation collaboratives in this overall effort that CMS is supporting to get to a better healthcare system. Kate, thanks so much for being here with us today.
Well, thank you so much, Mark. It's been such a pleasure working with the Duke-Margolis team and also with the state of North Carolina. We've had a lot of really fun and innovative conversations about where we're going next. So thanks for having us here. So Mark mentioned a very long and lengthy bio. I'm sorry to put you guys through that, but I'll just sum it up just for a second. I think, one of the things that one of the roles that I have at the Innovation Center is thinking about and helping our model teams think about what our multi-payer alignment strategy is. And we have set a goal, an aggressive goal, to ensure that 100% of our models, where applicable, have a multi-payer alignment strategy. And the other role, one of the other roles of many at the Innovation Center that I support is making sure that we have a patient-centered approach to the way we develop, the way we implement, and the way we think about the initiatives that we support across the Innovation Center. Those two things seem like they are miles away from one another, but from where I sit, they're really inextricably connected to one another. And I think about what's so important from a patient-centered perspective, the things that we are supporting providers and, or sorry, my face keeps changing over here. We're talking about really big macro transformation and really small micro transformation that happens at the point of care as patients are speaking with their providers, as they are meeting in rooms with their family and their care teams, all the way up to how do we solve for the big issues around commercial alignment, Medicare alignment, and Medicaid alignment. We can't change the way that people experience healthcare if we're not changing the way that we pay for healthcare. And we have to be focused on the things that are most important to patients. And those things include things like affordability, access, and care coordination. So we have to at least align on design features for models directionally. That happens physically as well. So said another way, we can't pay providers for healthcare in a fragmented way and expect to have seamless coordinated care. At the Innovation Center, we've delivered a lot of models that have had a multi-payer alignment strategy in the past. And quite frankly, we've learned a lot about what doesn't work. We've learned a lot about where we should go next in terms of creating flexibilities in our models and how we can support pulling together commercial payers with Medicare Advantage payers and Medicaid players as well. We know that if we align too loosely, that we send mixed signals to providers and unintentionally increase their administrative burden. Mark mentioned a couple of those areas, things like quality reporting. We were just talking with the great state of North Carolina earlier today about the opportunities for alignment around quality reporting, and things like use of multiple data portals. So, I mean, I hear from providers all the time that they're signing into multiple portals in order to access their data, which really just means they're receiving a fragmented look at their entire patient population. So we need to change that, and aligning, I think, around quality measures is one really easy way that we could, we've been trying to do this for years, but it is really one concrete way where we can support alignment. I think Mark mentioned also some of the alignment on data tools and aggregation, so that all providers have access to the right type of clinical and claims data to support them as they're trying to adopt a population health approach to care. We also know, and Mark mentioned this as well, that when we align too strictly, or we put too many parameters around joining one of the innovation center models, that we actually stifle innovation. That when we do that, we limit the ability of our commercial payer partners to think about their patient populations and how they can build flexibilities around them. And so we've been talking a lot with the Duke-Margolis team. We've been talking a lot with a lot of stakeholders about how we can create a path forward where we're directionally aligning around the really key design features that are important to reduce administrative burden and support providers to create that less fragmented, seamless, coordinated care. We also have learned, and this gets to the STCs, that, and everybody in this room is going to be like, this is a really obvious one, but healthcare is local. And for a long time, we were really trying to think about multi-payer alignment from a national perspective. But we have to consider that relationships are a part of everything that we do. Relationships happen, whether it's between the patient and their care team, bringing it back to that patient-centered focus, the relationships between primary care and specialty care, relationships between the healthcare system and community-based organizations, and the conversation and the relationships go on and on and on. But Medicare is a national program, and so we face issues with how we can align at the local level. We know that our commercial payer friends and partners have those same issues. Our national payer partner friends have those same issues. Flexibility is hard, and we have to keep working at it. And so I think convenings like this really support those efforts. The Healthcare Payment Learning and Action Network, or the LAN, as Mark mentioned, is a private-public partnership between CMS and our payer and provider partners with a goal of driving APM adoption across the US. Historically, the LAN has operated at a national level, and we've made progress in shifting away from fee-for-service toward value, but we're not there yet, and we haven't made enough progress. A few years ago, Mark mentioned we made some decisions to try to shift and think about how we could get to a much more local perspective. And that's where the ideas around the state transformation collaboratives came to be. We were working with a couple of other states, 4 states, and those include Arkansas, Colorado, California, and of course, North Carolina. We think that the STCs offer an opportunity for CMS and other national payers to learn from states, from providers, from regional payers, and others in the community about what you need, about what all of you need in order to support a broader adoption of value-based care and accountable care. We asked North Carolina to partner with us. And they very graciously said yes, so thank you for that, so that we could learn about the incredible work that's happening here, especially around the care coordination efforts that I know are set to launch very soon, some of the equity work that is happening in the states, a lot of the work that you guys are doing around social determinants of health. And we see that this is an opportunity to partner with states to learn much more about how we can flex those muscles and be much more flexible in our framework as well. A little later today, you're going to hear from Purva Rawal, our Chief Strategy Officer at the Innovation Center, and she's going to talk about some of the work that we've already done to create alignment. And I just want to mention that we've used what we've learned from STCs already to inform some of those alignment efforts. So for example, just yesterday, an article came out, a publication came out in the New England Journal of Medicine, where we were pointing toward a foundational core set of measures that we were going to be using across the Medicare program. Herb is going to mention that a little bit more, and I'm not going to get into the details, but we see this as an opportunity. We use the work that was happening in North Carolina to inform some of those quality measure sets as well. In addition, we have been really laser focused on some of the work here that you guys are doing around data infrastructure, building into the capacity for data aggregation around social determinants of health, and thinking creatively about ways that we can support some of that effort at the national level as well. It's informing our multi-payer alignment strategy, which you will see as we start to roll out new models in this year and the next year. And finally, it's been really helpful in supporting our strategy development around advanced primary care and specialty care. We're looking forward to partnering with you all. I'm really excited about today, but I'm even more excited about tomorrow and the following days, so that we can really, start to take this, what is a framework and an idea, and try to put that into action. So thank you all so much, and thank you for having us here today.
Safely, just one follow-up question. I know you covered a lot of ground with all the work going on at the Innovation Center over the past decade. That includes more than 50 different payment reform models. It seems like, though, that in addition to all of this work around opportunities for alignment, kind of getting it just right, not too close, not too overly prescribed, but directionally and meaningfully the same, especially in areas where we can improve provider efforts by payers working together. You've also come to, I think, it seems like a bigger conclusion around some of the learnings from these models. For example, some of the models that have worked are the accountable care organization ones, and the practical upshot of that is, like you said, stronger primary care, more aligned and better coordinated specialty care, and supporting that, quality measures that are meaningful, that can apply more broadly, data sharing. Is that a good summary of where you're headed? Because it seems like it's not only about, we're going to have to get into the weeds and details of what exactly is possible to align on to make it easier to move in these directions, but a lot of support here and a lot of findings at CMMI. It seems like that accountable care, whole person care, coordinated care is a long-term priority now at CMMI.
Oh, absolutely. You summarized that very well. I would add that, we can't do this from Washington, right? We can't do the alignment work from Washington. And you've named, I think, very, very helpfully some of the areas where we think that we can get to alignment early. And some of that's infrastructure pieces, right? So there's quality measures, there's aligning around some of the data aggregation and thinking about how we can use similar tools or shared tools with other payers in order to support providers. And then there's the convening, the infrastructure for convening, so that people can really create those meaningful partnerships. And again, we can't partner just from DC, right? So we really need to think about how we invest in that infrastructure, how we use that infrastructure to get to some of the weedier topics like benchmarking, like attribution, like risk adjustment. But in order to get to those conversations, I think we first need to have some of the earlier conversations around alignment and really invest and resource some of the infrastructure that we've been naming.
So technical details, but very important in support of the overall goals and bring down the burden and the administrative costs to our healthcare system to make this transition happen. Thanks so much for all your leadership and for being here today. Thank you, Kate. All right, thanks. And now I'd like to turn to Rebecca Whitaker for an overview of the initial path forward for the North Carolina State Transformation Collaborative. So Rebecca has been a leader at Duke-Margolis now for a while. She oversees our efforts around North Carolina healthcare reform in partnership with leaders from North Carolina Department of Health and Human Services and leaders and stakeholders from throughout the state. This has involved a lot of work in interviews, analysis, convening to get us to this point for an initial roadmap for the State Transformation Collaborative. And Rebecca's in a great place to do this as a research director at Duke-Margolis focused on state and regional healthcare transformation activities. Thanks so much, Rebecca. I'll turn it over to you.
Right. Thank you, Mark. So yes, as Mark was just saying, in 2022, we at Duke-Margolis completed some preliminary interviews and hosted convenings to identify strategies and potential actions for multi-stakeholder alignment in payment and delivery reforms through the North Carolina State Transformation Collaborative, or STC, as you've heard us refer to it. We organize these priorities in this summary framework that you see here to describe the North Carolina STC. And the goal for my talk today is really to tee up the discussion to follow on the agenda by highlighting some of the strategies for the North Carolina STC and outlining some of the proposed long-term goals and short-term actions across each of the strategies. If you want to learn more about how we developed this summary framework, I'll point you to our one-pager that you can find on our website that was circulated in advance of the event. For folks online, I think we'll drop that link in the chat as well. So the strategies depicted here and the specific actions outlined on the slides that follow are motivated by a few key goals, which we also identified through stakeholder feedback. And those are in the blue boxes here and include improving population health, advancing health equity, enhancing the patient experience, relieving provider burden, and reducing healthcare costs. And we aim to work toward these goals by strengthening coordinated and accountable primary care, by aligning on quality measures, enhancing health equity data, and improving data infrastructure. And taken together, we hope that these strategies will be early steps toward this overarching vision. So by securing and implementing an agreed path forward for alignment and action, we can make progress both within Medicaid, but also beyond Medicaid, including in the Medicare space, Medicare Advantage, and commercial payers as well. So following this presentation will be a series of opportunities for folks to provide feedback on this framework and the specific areas to prioritize for short-term and long-term actions. And after today's discussion, we aim to have a sense of the priority areas for short-term actions, things that we can do together over the next 6 to 12 months through the North Carolina STC. Progress on these long-term goals can help can build on this foundational short-term work. So the slides that follow are going to detail some of the proposed long-term goals, short-term actions, and concrete steps for each of those 4 strategies. So if we go on to the next slide, for strategy area number 1, which is strengthening accountable and coordinated primary care. The long-term goal, we heard a strong interest in developing and implementing primary care value-based payment models in North Carolina. That would be designed to help reduce inefficiencies and administrative costs, and doing this through a 2-pronged approach. One would be greater investments from payers in primary care, alongside a glide path or sort of an on-ramp to value-based payment that encourages diverse provider participation. And so some of the short-term actions we identified through conversations with you all include reducing provider burden and supporting transitions to value-based care. So we heard a lot of support from both payers and providers alike on aligning quality measures as one example of aligning on key administrative components, and building the data sharing and capacity to support that performance measurement. We also heard about the need to provide upfront investment and supports for primary care providers to enable high quality coordinated care and to facilitate provider readiness to engage in value-based care models. And there are lots of examples that we can leverage in this work. State-based efforts to align quality measures across payers, including like the Washington State multi-payer model. There's the ACO REACH model, which is a new model out of CMMI that provides some guidance on structuring upfront supports, and as well as the LANS Accountable Care Action Collaborative and the Accountable Care Curve for facilitating provider and payer readiness to engage in value-based care. So moving to strategy number 2 and aligning on quality measurement. Certainly the long-term goal here is starting with alignment on existing quality measures could help chart a pathway for future work to modify those priority measures and incorporate new measures, especially patient-reported ones. And so some short-term action steps here focus on aligning quality measures across key population groups, so pediatrics, adults, older adults, starting with some existing measures where we know persistent disparities exist. And then from there, using that aligned priority measure set to measure and identify disparities. We heard a lot of interest in leveraging aligned quality measures to reduce disparities through coordinated action, which is a lot more achievable if we're focused on the same priorities and measuring things in the same way. Again, several state examples we can look to guide our work here in California, Oklahoma, Rhode Island, as well as Oregon and Louisiana and Massachusetts that provide examples on promoting accountability for reducing disparities. Switching to strategy number 3, enhancing health equity data. In order to make meaningful progress on advancing health equity, we heard about the need to develop standardized approaches to the direct collection of health equity data, which would include race, ethnicity, language, sexual orientation, gender identity, disability, social drivers of health, and as well as to establish some learning collaboratives to facilitate implementation and use of these data. From there, we can apply valid and reliable set of aligned health equity data to identify disparities and help drive multi-stakeholder collaboration to reduce gaps in services and improve clinical outcomes. So in the short term, we certainly heard about the need to start with what we have and improve the data that we currently have by standardizing data storage formats and the way that we're reporting data by different population groups. And those sound really boring and mundane perhaps, but are really critical to the future work. And then identifying best practices and protocols and help spreading that work to other organizations. We also heard about a need to move on standardizing the direct collection of data sooner rather than later, especially in those areas where we truly lack good data now. And I'll give a shout out to North Carolina DHHS here, who's done a lot of great work in this space, including as part of the COVID-19 vaccine management system that we can build on. So finally, our cross-cutting strategy here is improving data infrastructure, truly acknowledging that, that improvements in data infrastructure are necessary to support potential short-term actions and long-term goals across all of these strategies. And critical to this will be advancing the health information exchange in our state, as well as efforts to develop and implement strategies to support small and independent practices in data exchange. So in the short term, how can we look at opportunities to support the adoption of bulk data exchange using standardized data definitions? Are there opportunities to build in incentives for data quality and data exchange? What steps can we take to start building this infrastructure, for example, on the priority quality measures or on the health equity data that we talked about a little bit earlier? So there is a lot here to talk about, obviously, and we want to hear from you on the top 3 or so areas for short-term action. We also want to hear if there are important steps that you don't see reflected here. So we welcome input on these strategies, potential short-term actions, and example concrete steps later during the open discussion, and as well as through a survey that we'll be distributing after today's event. So for now, I think I'm going to turn the microphone back to you, Mark. All right.
Just for a moment, Rebecca, thank you so much for that overview. You covered a lot of ground there. And I think Rebecca's comments highlighted, look, care transformation is not easy, but there is so much support for moving in this direction that paying attention to the details matter. But we don't want to lose sight of the big picture, why we're doing this. That's what's going to keep these efforts motivated and keep us working together on solving these very important steps to get there. And for that, I'm very pleased to be joined today by the North Carolina Department of Health and Human Services Secretary, Cody Kinsley. Cody, I know you have a very busy schedule. We build flexibility, as we said, we're finding the right balance of flexibility and structure in this work. So pleased to have you with us today. I'll turn this over to you. Thank you.
I'll just use this mic here.
Great.
I walked right in as Rebecca was talking about reducing administrative burden, and I was like, "Ooh, yes, please." I apologize so much for being late. This has been an exciting block on my schedule for some time, and I'm really happy to be here. I want to first thank all of the collaborators who have been working so hard to get to this point, to this launch. I spend a lot of my days talking to legislators. And most of that is, at essence, trying to convince them that putting money in the right place would get them more value for what they're trying to achieve. In government, I call these wrong pocket problems. We spend a lot of money on incarceration, on social services, on county issues, that if we put more money into health coverage with higher value, we could see opportunities to save those resources and put them in the right place. I could go on and on with like 17 other examples of how investing in health is a smart investment, but I think that that would actually definitely, certainly qualify as preaching to the choir in this. So I won't do that. But the concept of actually trying to move the resources and think differently about how we spend time budgeting those resources is not easy. In my context around the legislature, it's built on appropriation cycles and committees that have always been vested with the responsibility of using those resources in a certain way, and then budget caps within their appropriations and and getting them to play across the lines. You know, this turns into a big complex, what I also call a color of money problem. Some dollars can be spent here, some dollars can be sent somewhere else. And for everybody else in our country, they're like, I thought money was green. And it doesn't make any sense. I tell this story simply to offer what I hope is perhaps a macro parallel to, I think, the exact challenge that you're facing in this effort. And the opportunity to try to rethink and align to value. We all know the basic premise of the problem, which is that we spend an exorbitant amount of money on healthcare in this country for very little output relative to the dollar. And we're desperate to try to change that. And we've been on this journey around value, and it has been a journey with many steps along the way. And I am so excited about this particular partnership because I believe it creates the right ingredients for more meaningful and aggressive success, which, oh my gosh, we are so in need of desperately. The current trajectory is not sustainable, not to mention here in North Carolina, around our aging population and all the other drivers, we have got to modernize faster. Rebecca mentioned data, a powerful tool for thinking about this differently. Oh, gosh, this is not a test. And also mentioned COVID. And I think our work in the COVID response offers perhaps a parallel of what we're trying to do here as well, which is that for the first time, we had a mandate for action. We had the partners necessary in the room, and we had clarity, and we had focus. I have never been so gifted than the ability to tell people, I can't do that right now, I've got to do this. And I think that this project is designed, this partnership is designed around the concept of how do we stay really focused on proving out the point to make sure we can really deliver on value and rethink the way this works. I'm really excited for this. Our department is incredibly committed to this. You know, there's going to be a lot of enthusiasm right now at the launch, and sometime there'll be a slip. We're going to be there to scream about how important this is, because every day in North Carolina, there are millions of people that will benefit from this work, and we're going to do our best to make sure that they stay at the forefront of your thinking and why we're launching this and why we're pushing forward full speed. I want to thank Mark, who has been a phenomenal collaborator on a number of fronts, of course, our federal partners, and everybody else that has played a role in this and that will continue to play a role in this, because the truth is that, you know, there's something else we learned in COVID is that this mantra, you know, I came home to North Carolina in 2018 with a passion of changing the way that we do mental health. And my kind of mantra in that work has been nothing about us without us. And I think the thing that we have to constantly keep at the center of this work is obviously the people that we are serving. And how do we wrap around them differently? And in North Carolina, that's 22% that are Black or African American, or 10% that are Latinx. Some number that are uninsured and won't have access to insurance because of the current access to coverage. 1 million people uninsured, we're going to fix that this year. And a lot of other things. So I appreciate you keeping the people that we're serving at the center of our work to really think about equity in a way that we can drive value, because too often we achieve efficiencies by cutting off the people who are just easy to forget. And that's not real efficiency. And so I really applaud the work. I'm really grateful to be here, and I'm looking forward to listening. Thank you.
Thank you very much, Ms. Secretary. Really appreciate your being here. Well, you've heard from Secretary Kinsley about why this is so important, about the department's commitment to the goals of person-centered care that doesn't leave anybody behind, that addresses mental health issues, integrates them, and it works for all North Carolinians. You've heard from Rebecca about the specific steps that we've initially identified based on the discussions and input from many of you that could be the focus areas, the specific steps that make it easier to achieve those goals. I'd now like to turn to Shannon Dowler. Dr. Dowler is the Chief Medical Officer for North Carolina. She joined North Carolina Medicaid in 2019 as Chief Medical Officer, and her past experience with Medicaid includes chairing the Physician Advisory Group for Medicaid for many years. In the COVID pandemic, she led efforts across DHHS related to telehealth and health equity with a focus on increasing testing and vaccinations, a process that gave us some good ideas and models for how to collaborate and how to reduce the burden in doing so. Shannon's also spent a lot of her career in the service of nonprofits, including the local health department, a large federally qualified health center in Western North Carolina, and prior to joining Medicaid as Associate Chief Quality Officer and Chief of Community Medicine for a health system focused on integrating healthcare and reducing unnecessary or avoidable variation just so we can get more value and more equity. And Shannon's going to help connect these big goals that you've heard about from the Secretary, the specific potential steps you've heard about from Rebecca, to the strategy that DHS is implementing in support of making progress. Thanks, Shannon, for being here.
So many human beings in the same room. This is so exciting for me. Thank you. Thank you for being here to help us celebrate the launch of this initiative and this important work that we're doing together. I think we have to acknowledge that, albeit unintentionally, payers, public and private, have been a major cause of provider exhaustion and contributor to burnout for an entire generation of physicians in our collective quest to achieve the quadruple aim. I am not throwing shade at the quadruple aim. I love it. I reference it all the time. The flaw in the aspirational vision of the quadruple aim is that in order to know we're getting the right care for the right person at the right time, it requires this tremendous investment of data. And the collection and production of that data has fallen to the providers on the ground taking care of the people. And that's undeniably and unintentionally impacted the caregiver's ability to achieve that fourth aim, which is that exceptional caregiver experience. By the time I left my work as the ambulatory CQO at the health system, our primary care providers were being held accountable for several hundred clinical and operational metrics every day. I counted them. There was a spreadsheet. They were not duplicated. It was several hundred measures. Meaningful multi-payer alignment has been elusive, but do we have a choice about this? With a rapidly aging and ailing population and a measure of burnout unprecedented in the history of medicine, I maintain that we have an obligation as payers to no choice but to band together. We have to put aside our individual needs and goals and simplify collectively. This STC partnership is a critical opportunity to make progress here in North Carolina, but also to show others around the country that it can be done, but not just done, but done with excellence. North Carolina Medicaid has been very public about our strategies to achieve value-based and person-centered care for North Carolinians. As we've transitioned to manage Medicaid, we have two major levers for VBP. We've got our MCO contracts and building upon provider-based models. But it's not just the payers and providers, is it? We know we're not going to be successful without our community partners that patients have a tremendous amount of historical trust in. People like here in Durham, the nationally recognized HBCU North Carolina Central, El Futuro, Legal Aid, our disability rights partners. There are so many that help us get this work right. We've invested in Medicaid in a very local, patient-centered, practice-based care management approach and our advanced medical home model designed and led by Kelly Crosby. And the data says it's working. Our tier 3 practices have significantly higher rates of care management touches, and our early data suggests that our health outcomes are better in that population as well. We've pushed the envelope on providing health-related social needs through our innovative Healthy Opportunities pilots led by Amanda Van Fleet. We continually stretch the boundaries of strategic integration of behavioral and physical health, as demonstrated by our multi-payer, multi-stakeholder collaborative care consortium that launched last year. We do see 2 major opportunities in the short term with the State Transformation Collaborative: aligning on quality measures and definitions to reduce provider administrative burden, and refining our data infrastructure to promote sharing data across payers and providers more consistently and efficiently. While that important work is happening, Medicaid remains committed to reviewing how we use things like prior authorization and other burdensome levers to ensure we're not inadvertently exacerbating health inequities and contributing to low-value care. From a longer-term perspective, we believe at North Carolina Medicaid that primary care providers need flexible spending models that work for them. Multi-payer alignment is foundational to our shared success on prospective payments and ACO models, not just alignment on the quality measures, but agreeing on what services are included in those bundled payments and prospective payments. How are patients attributed consistently and accurately? And when can we finally move our collective mass out of that ineffective fee-for-service canoe and shift over to that luxury population health model that's just waiting for us? Finally, and because I am a strong believer that anything that can be said should be said in rhyme, I'm going to leave you with 2 limericks from Team Medicaid. Here's to our investment of renewed energy, shared success sown by seeds of synergy. Together we'll build a collaborative guild with magical thinking and collective wizardry. To achieve means we commit the whole team, open dialogue key as we're dreaming the dream. Our time, it is now. Now you tell us how, so our STC launches ahead with full steam. Thank you so much.
So I think thank you. I really appreciate the limerick in advance of, for those who don't know, February 14th is Health Policy Valentine's Day. So appreciate the limerick in advance of that too. No, Shannon, thank you so much for your remarks and just thinking about sort of the vision for success for what this STC can accomplish. And there's lots of levers that Medicaid has and is already using, as you talked about, to reduce burden and improve whole person health and really enable both, patient experience, but also provider experience. So what is, for you, kind of what is the vision of success for the STC even beyond Medicaid look like? And how can we all be good partners in that work?
I think we've got something in North Carolina called the Payer Council, and it's where all the payers get together on the phone or on Teams or whatever the thing is, and we try to work together to make sure we're doing things well. And I saw in COVID that Payers Council was really effective. We all got together and said, this is how our individual entities are going to be covering telehealth. And we made it so it was easier for the providers out in the world to see, oh, here's this one pager and I can understand what's happening. So we already had the seeds of payers working well together. I think we all have to just leave all of our agendas. We all have agendas. We all know where we're spending money and where we want to save money and where we can do better care. We're going to just have to leave some of our individual interests behind. And all of us agree that we're not going to all get whatever we want. And we got to trim down that 300 metric list that's on top of every primary care provider. And let's come up with like 10 or 15 things that we can all agree on. That's the thing I'm excited.
Thanks so much. All right, well, now we are going to shift into a panel discussion with 4 North Carolina leaders who will reflect on the strategies and actions and example steps that we've been talking about here today. So I'm gonna kind of read out a bio for each of them while they make their way up here. First, we have Dr. Mark Gwynn. Mark is the president of UNC Health Alliance, University of North Carolina's clinically integrated network, Next Generation, and Medicare Shared Savings Program Accountable Care Organizations, and Population Health Services Organization. Dr. Gwen brings extensive experience developing high-value clinically integrated networks and data-driven value-based care delivery to complex patients across diverse geographic regions. UNC Health Alliance has a network of over 6,500 employed and independent providers, 16 hospitals, and 35 post-acute providers. We also have Dr. Karen Smith. Karen is an independent family physician in Rayford, North Carolina. After serving patients at a small rural health center in partnership with Cape Valley Health System, and then as medical director for system-based regional practice with First Health of the Carolinas, Karen established her own independent private practice in 2003, so 20th anniversary this year, congratulations, where she and her staff provide comprehensive family medicine. Recognizing the unmet needs of the people she served, she became involved with the North Carolina Academy of Family Physicians, where she participated in several levels of the organization and subsequently became president in 2005. We also have Dr. Stephen Friedoff. Steve is the Senior Vice President of Healthcare Services at Blue Cross and Blue Shield of North Carolina, where he's responsible for relationships with healthcare providers, medical policy, corporate pharmacy appeals, care management, and overall leadership of Blue Cross North Carolina's healthcare division. Dr. Friedoff is a seasoned executive with more than 20 years of experience in clinical, academic, and administrative leadership roles. And last but certainly not least, we have, turn to my page, Kathleen. Kathleen Schwartzwalder. Kathleen is the Market Vice President for Humana in North Carolina, where she leads Medicare Advantage health plan strategy and operations. She's been with Humana since 2013 in enterprise and market strategy roles across multiple markets. In her market-based roles, she's been instrumental in growing regional membership and in launching several unique provider partnerships that further integrated Humana's capabilities with providers' capabilities to better serve members. Kathleen is passionate about the member and provider experience and partners across the organization to support member needs through plan design, driving success with value-based care providers, and supporting clinical and health equity strategies. So thank you all so much for taking the time to be here with us today. I am going to kick this off by turning to you first, Mark. And in your role at UNC Health Alliance, you've helped providers focus on a few key priority measures rather than try to get their arms around the multitude of measures. We've heard hundreds as some examples. So what lessons would you draw from this experience that we could apply to the North Carolina State Transformation Collaborative and efforts to align quality measures across payers? And where are there opportunities to advance health equity through alignment on a few key quality measures?
Thank you. I appreciate it. First of all, I just want to say how exciting it is to be in this room with leaders and forward-thinking folks across the spectrum of payers, providers, and community members. And I'm really optimistic about this work together. So we have such a good substrate in our state. It's really exciting. Many things that have been said today resonate with me, both as a family physician, but also in managing our network across the state. Alignment around key administrative components of alternative payment models and value-based contracts is critically important, whether it's attribution or benchmarking or quality measure sets. It's really easy to engage a physician around the concepts of value, better care, more affordable prices. That's really easy. It's much harder to engage providers around how we deliver that and what we put in front of them and operationalizing the concepts of value. And that's where we spend a lot of our time focusing. And Shannon, it was very interesting. We looked at all of the quality measure sets across our 14 contracts, and there were 158 different measures. There's not a single provider in the state that can pay attention to 158 different measures. But what they can pay attention to is 10 or 5 really important measures that have good evidence that frontline care teams care about, and through my lens, have a financial implication for our network and help support further work. What they can focus on is how to redesign care around hypertension, not necessarily what is the exact threshold of a hypertension measure that will achieve financial results. So we took all 158 measures, we narrowed it down to the top 20 based on those 3 criteria: evidence-based, what our frontline care teams care about, and what the financial implication will be across our portfolio. And that's what we focus on. And every year we whittle that down to 10, and we focus on 10 a year across our network. That's doable. We can translate that then into how we support providers and practices, whether it's with coaching, whether it's with data, point of care decision support. We can alter our EMR for point of care decision support to support those efforts. That's actually doable. And we've been doing that for the past 3 to 4 years, very effective. The other key area that resonates with me and the folks that I represent are focusing on health equity, but through the same lens, taking the broad concept of health equity and really narrowing it down to something that's actionable. We've had a really nice partnership with Blue Cross Blue Shield over the past year. Between April and December, we focused on 3 areas: diabetes control, hypertension control, and colorectal cancer screening. And we agreed on how are we going to define disparities, how are we going to define populations, and what are the goals. And in 9 months, we reduced diabetes disparities by 25%, hypertension disparities by 25%. And for colorectal cancer screening for this particular population, our colorectal cancer screening rates for our BIPOC populations are actually greater than our white population. This is doable. It's concentrated effort, and we've learned a tremendous amount in a really nice partnership.
Yeah, really great evidence to support this approach here too. So thank you for sharing that. Dr. Smith, I'm going to turn to you next. And from your perspective, which concrete steps would meaningfully reduce administrative burden experienced by independent providers like you? What other considerations should be top of mind for supporting independent practices and moving toward coordinated, accountable care and continuing to allow them to excel?
Thank you. I appreciate it. And I really definitely appreciate being in this room. For 28 years, we have worked on health equity. I've been in practice, as you've noted, since the year of 1992. And it was amazing to me when I came into the office, when I started seeing patients, the difference, what was happening, depending on where a person came from, where they live, how they spoke, what their background was. Why was there a difference in their outcome? And for us to now be sitting in this room and finally, not finally, but really getting to those concrete steps. So I appreciate the comments that I just heard in regard to aligning those measures and kind of fine tuning them, getting them to the point where those of us who are in the trenches, shall I say, last year I saw 14,000 patients, the same workflow for every patient, and having to collect quality measures on 14,000 patients. And now we're even looking at CPT-2 codes. And now we're looking at capturing our BMI in terms of our class 1, class 2, class 3 obese. So now we're capturing all of this information. And the question that I ask everyone sitting in this room is, where do we have our value? What is the value of that doctor who is taking care of the patient? What is the value of the team, the advanced practice providers who are taking care of that patient? And what is our primary care spend? How much are we actually allocating to allow these activities to take place and to make sure that we have the tools that's necessary? My IT gentleman just said to me, well, you need to update your computers. And I said, well, I did that when I put my EHR system in. He said, well, you put that in 2003. I said, so where do I get the funding to update my system so that I could collect this data, so that I could turn this data in, so that I can make sure that we're providing quality? And so when we talk about alignment, and if we can start with where is our value? Where are we placing our financial investment, allowing physicians to do this? For those 14,000 patients that I saw, are we paying enough for those activities to take care of? We can demonstrate the outcome because we're doing it. And so I really hope that we get to that point in our discussion. We can collect all kinds of measures. We can do that, but you're right, metrics that matter. That's going to make a difference. That's going to improve the outcome.
Great, thank you. Steve, coming to you next. In partnership with major health systems, Blue Cross Blue Shield of North Carolina launched Blue Premier, which is a value-based program tied to healthcare performance and outcomes. So from your experience, what are some lessons learned from the Blue Premier program that could help inform the state transformation collaborative efforts? And where do you see opportunities for multi-stakeholder collaboration across primary care, value-based payment models that could help reduce inefficiencies, putting value in the right places, as Karen was just alluding to, and help providers move to value-based care models?
Sure. No, thank you very much. And again, thank you for having me here. I've had the opportunity to have, and so have others in my organization, have a lot of individual conversations with organizations represented in the room, but I think bringing all these groups together is wonderful because those one-off conversations certainly help and do advance what we're trying to accomplish, but doing it in that manner only adds to some of the fragmentation rather than trying to pull it all together like this. So really appreciate that. I'm a family physician by background and with 20 years of practice experience, and I tend to have a bias of looking, through all of this through that lens. And if I look at sort of the early days of our program, Blue Premier, one of the things that was the most striking to me when I first came to Blue Cross just a year or so ago is that we have to find ways to pre-fund or help primary care physicians, especially independent primary care physicians, build on the model, just as you were describing. Where does this kind of funding come from in order to help you be more successful in value-based care? And I think one of the lessons that we learned actually during the pandemic, ironically, which was obviously not intended when Blue Premier was first rolled out, was that as everyone in healthcare, but primary care practices in particular, we're seeing just tremendous drops in revenue during the pandemic. And, we were brainstorming, the team was brainstorming at that time of, how do we support those practices? Ultimately came up with distributing about $20 million to those practices. There's roughly 500 of them, impacting about 500,000 patients on a per patient basis that was paid out. And the reason I'm bringing that up is that a very significant number of those practices subsequently enrolled in the Blue Premier value-based care program. And I think there were probably two major factors involved. One was a pretty significant upfront investment in primary care. And second, once you get beyond the financial, once you get beyond the technological hurdles to doing so, one of the fundamental aspects of it is trust. And at least at the time, that investment seemed to go a long way into building some of that trust. But as we look back now over the last 3+ years, where Blue Premier has been deployed, it's been successful. We've saved about $500 million in medical costs by improving health outcomes. 2/3 of that have actually been distributed back to the providers themselves. About 1/3 of it has gone towards making healthcare more affordable and our rates and whatnot. But we also recognize that the program needs to evolve, and there were places and there are places where it does need to evolve. So part of that process has been, we've involved numerous of our ACO stakeholders giving us feedback on, what's working, what's not working. A couple of examples is, how do we do a better job at data sharing, as it came up numerous times earlier, and doing so in a bi-directional fashion and turning that information into, or turning that data into actionable information, and doing so in a much more collaborative type of an approach. So I think when you think about it, for me, a huge piece of it is how do we better enable primary care physicians, especially independents, to be able to make that leap into value and do everything we can at the same time to help with the administrative simplification of whatever program we deploy.
Yeah, a lot of valuable lessons that we can draw on there. So thank you. And Kathleen, from your perspective, where are there practical opportunities to enhance health equity data across payers and lines of business, and where, where's a good place to start?
Thanks, Rebecca, and echo the comments of the group that it's really great to be here today and to be dialoguing on such impactful topics, have momentum together, because I think the opportunities really lie in how we collaborate on these topics and these opportunities. And so I think about, where there are existing value-based relationships, where there are existing partnerships and collaborations and intersections of patient populations are really great places to start to look at how are we doing from an equity lens. And so, selecting a small number of measures, a small number of focus areas, and working on that together across the payer and the provider, or across multiple stakeholder groups where there's alignment and incentives to work together, can allow us to really move things forward. One of the areas we've been focused on at Humana is enabling that through data exchange. And so we've been looking at which electronic health record systems a lot of our partners are using. And you've got your large systems that have one approach, You've got your more independent provider practices who may have a much broader array of EHR systems that they work with. And so we've been targeting different partners to build data integration solutions with, and do continue to expect that to be a key part of how we deliver on and work on health equity and advancing value-based care over time. It also helps really make progress on that provider administrative burden pieces, because a lot of that can be enabled more automatically when you have those connections built.
Absolutely. Thanks so much. So we're going to end this panel with a question for all of you. And I'm going to put all of you on the spot a little bit here and say, where do you think are the greatest opportunities for practical alignment through the collaborative? We've heard a lot about data and quality measures and equity. And so, which strategies or steps do you think would be most helpful to prioritize in the next 6 to 12 months to achieve progress? So where do you all think we should start, and the data supports maybe that we need in order to accomplish this work as well? So maybe I'll go down the line here and end with you, Karen. So Mark, let's.
Sure. I'll say again, I think narrowing our quality measure sets is critically important. I do think, though, that measuring quality across populations is critically important. And as we're looking at the CMS's directive around ECQMs, we're learning a lot. The variability across populations, even within practices where our measurable quality has been really high, is really significant. So as we think about reporting on measures across populations, having a reasonable way to do that, I think, is important. I'll mention fire. That's about all I know. The details are deep. But something like that, I think, is really important. We're looking at vendors to do this work that are going to cost us about $2 to $5 million a year. I can spend $2 to $5 million a year redesigning care for our really complex, vulnerable patients. I don't need to spend it on a vendor to do that work for us. So I think aligning around really operational details like that is very important.
So my answer might be a little bit atypical. I agree with everything that Mark said. And I think my answer is true, whether it's regarding data sharing, whether it's regarding administrative simplification, development of new models, et cetera. I think whether it's patients, whether it's providers, whether it's payers, whether it's other stakeholders, I think we have to figure out a way to build trust that we're all going for the same goal. I mean, patients are often very reluctant to share their RAL data with us. Employers are sometimes reluctant to share that with us. Payers and providers, we frequently are trying to figure out interoperability is certainly a challenge, but I think sometimes the greater challenge is having that trust between the payer and the provider to be able to have an exchange. And frankly, even between payers, how do we all have incentives around why we've aligned on certain quality measures, for example. How can we, have that vulnerability and have that trust that by doing this and by exposing some of that vulnerability and maybe letting some things go, that we ultimately are going to be doing a better job for patients and healthcare overall.
Thank you, Kathleen.
I think where I would say is, can we align on health equity measures in a couple very focused areas? And I would imagine that there are probably some that would rise to the top if you were to poll the group, right? And so if we can prove that we can drive progress on a few things, we'll gain lessons on how to expand and extend that work more deeply.
And Karen, last word.
And then I would say shared vision. Where do we want to be? How long is it going to take us to get there? What is the shared vision? Because when all is said and done, and I go back to my shop, I go back to my practice, I have to be able to sell this concept to the people who are actually going to be doing the work. And so I want to make sure that when I tell them this is the vision, this is where we want to be, that they know that you're just one small part of a component of group. But guess what? There are a lot of other folks that are working with it. We can also collaborate. The community efforts that we have, that we can bring those efforts in So in the end, what we have set out to do is going to make a difference for what the group as a whole has a shared vision.
Yeah, that's such a great point, and really appreciate the discussion here today and hearing a lot about going back even to something that Kate said at the beginning, really to improve health and health equity, we have to start changing the way we pay for things in order to develop better models for patients and for the providers delivering that care. And so, everyone here kind of touched on that as well. And how do we help providers do this? And how do we help providers, deliver value-based care, and where do we need additional investments, particularly around data and simplifying systems to enable success. And then finally, how do we do this together? And, Steve, you pointed to building trust, and that's really, really critical, both between payers, providers, patients, families, communities. That, this is all a trust building exercise. And especially when we talk about health equity and health equity data, making sure that we're approaching this in a way that everybody feels supported and bought into. And then finally, that shared vision and shared purpose, Karen, I think that is really critical to make sure that, when we're all working toward the same goals, we can go a lot farther. So appreciate all the insight you shared today, and looking forward to continuing the work together and the discussion. So now I am going to turn it back to Mark, who's going to do some facilitation for an open discussion with you all in the room today. And with folks online, where you can turn back to Slido to facilitate some reactions, comments, questions in that way as well. So Mark.
Oh, there we go. There we go. Okay, all set. So number of perspectives already in this discussion and some common ground. Now I'm going to be taking a seat here in the middle of the chairs up front, but this is really a conversation with all of you here in the room and all of you who are joining us online, where we very much like to hear from you about priorities and next steps for the State Transformation Collaborative. We got here thanks to all of the input to date around key priorities, and this is a chance to add to that. So we've got some time to do this. For those of you who are joining us online and in the room, Slido presents some opportunities for comments as well, but also would appreciate comments that you all would be willing to make here in the room, or if you can submit them online, we'll read those here in the room too. So let me open this up to people, to everybody who's with us today. You took the time and effort to come. This is a collaborative project. We need to hear from you. Some of the things that we've heard about already, as you just heard Rebecca summarize, are quality measure alignment. There is a lot of variation on key goals where there seems to be a lot of commonality, whether it's around diabetes or preventive services or risk factors like blood pressure, and not only ways to align key measures in these areas, but to make sure we're paying attention to equity as part of that as well. There's a push for maybe several priority areas, both for aligning the measures and incorporating attention to race, ethnicity, rural, urban status, things that really affect access to care, and that we know we can work together to address. We heard about strengthening primary care, and both from the state efforts like at Blue Cross, the Blue Cross initiatives and the Humana initiatives. We heard about the efforts that Medicaid has undertaken for supporting advanced medical homes. We heard about the national efforts that CMS is supporting. Again, this isn't just more money for primary care, important as that is, it's more money to support advanced coordinated care models that can track how we're doing on these important goals. So how can we align further on those efforts as well? And everybody has noted the importance of data, timely and accurate information, especially key pieces of information that are tied to these specific priorities. So it's hard to do work on addressing health equity without having good data on race, ethnicity, language, socioeconomic status, community barriers, things like that. A lot of work that's already been done in this space during the pandemic, addressing issues related to equity. More that we can potentially do. So those are some of the topics that have come up, both in terms of supporting the broader goals and specific steps. But let me open this up to all of you and initial thoughts. Yeah, please go ahead. And if you don't mind, just letting us know who you are when you make your comment. And again, for those of you who are online, we want to hear from you as well. Use the Slido and the ability to submit comments that way.
Thank you very much. My name is Sharon Williams, and I feel much like a mosquito at a nudist camp. I know what I want, but I just don't know where to start. So I am here with representatives from the University of North Carolina at Asheville. They are a group who are working with community-based organizations in North Carolina, particularly the area agencies on aging. Heard lots of great information here and just want to share that 80%, and you guys know this, 80% of all health outcomes are driven by social determinants of health. These AAAs and other community-based organizations are the drivers of delivering those critical services that help you get those people into chronic disease management courses, improve self-management outcomes, and we'd like to know how UNCA and its constituents can be more engaged to support this North Carolina transformation.
Well, maybe if you don't mind my asking a follow-up question here, again, just putting everybody, this is a collaborative effort. As you know, the state, because you all have been involved in much of it, the state has tried to take steps in Medicaid reform, working with the health plans and providers like the ones you're working with across the state to identify these social risk factors, these social drivers that get in the way of getting good health care and better health and well-being. And some priority areas include housing security, food and nutrition, and there are data systems that are starting to come together to address this. NC Cares 360, Healthy Opportunities Pilots, sorry for all the buzzwords for everybody who's not following closely, but I know many of you are, but it does come down to the right data on the right person. How do you get it? Any specific steps that you'd suggest on bringing the data piece of that forward, accelerating progress on identifying and being able to act on these social needs, since there so much is happening in payment reform to try to address them?
Absolutely, and as you mentioned, you know, starting this year, NCQA is requiring its plans who are going through accreditation to do screening for 3 of those risk factors that you identified. You'll have to report out on them, not just the screening, but the delivery of services, and you'll be required to report out on them in 2024. The community-based organizations have been doing this social determinant of health screening, particularly the AAAs, since 1970, when the first AAAs were introduced. So they have a warehouse of that data. I think the biggest challenge is their data is in Greek, and what the healthcare system is looking for is in Romanian, and you know the two don't match up. So how do we create that collaborative, a community integrated exchange that aligns with the health information exchange in the states, so that that data can be interoperable, and it's, you know, a closed loop referral system, so that it's not plans and physicians sending requests for services out and never know, did you get the service? Did it help? What was the impact? And so I think some more talk around how to help community-based organizations communicate with the healthcare system, ecosystem is a really critical next factor in really closing the loop on social determinants of health, and health equity being one of those critical aspects of SDOH.
Great, thanks for that comment. And I think we can definitely follow up on what to prioritize, you know, working with organizations like yours on starting to close those gaps and make sure the right data is flowing. Great. Other comments in the room? Okay, one more here, and then I'm gonna go with Yolande's help to go online.
Hey, good evening. Kristen Dubé with the North Carolina Community Health Center Association. I have a question around, am I too loud? Alignment of measures. I'm kind of curious at the federal level, how much the different agencies are talking about alignment of measures. So we report uniform data system measures to HRSA, and it's been really interesting through the North Carolina Medicaid program. We have one measure that we've been looking at in Medicaid, and we're performing we're great on everything, but let's say maybe not as well as we had expected, especially considering what our UDS data show. And come to find out, the UDS measure is totally different from the North Carolina Medicaid HEDIS measure. So how, like, what is the federal government doing to talk across systems? I think also like the Department of Veterans Affairs collects data. What are they doing? So how are you kind of connecting the different departments to say, what can we align more closely at the federal level to help those of us down at the local level?
Great question. One of the nice things about this local conversation we're having is we actually have CMS and the federal government right here at the table with us. So Kate.
Yeah, I'm going to tag team and see if Purva has anything to add here. So, we've been doing a lot of work trying to think about how we can create an aligned core measure set or foundational measure set that we can use across Medicare and will be inclusive of Medicaid. And so that is something that came out in a publication yesterday that I think I mentioned. It's in the New England Journal of Medicine. And we actually worked through the STCs to try to understand what measures were being used in the states and did a crosswalk of the STC states to understand are there certain measures that are similar across what's being collected in those states? So that was one effort. We also at the Innovation Center have been really committed to trying to create an on-ramp for safety net providers to participate in our models. And so as a part of that work, as we've been designing and thinking about models in advanced primary care, but also in other spaces, we've been working with our federal partners versus one of them to think about how we can create a measure set that will hopefully be more aligned with some of the work, be supportive of ensuring that FQHCs could participate in a future model. Is kind of how I would frame that. I don't know if what the work is related to some of the other agencies. I don't know, Purv, if you have anything to add there.
No, I mean, I think you asked a great question. And I think Kate cited the paper that thankfully came out yesterday before this event, because I think it's something we would love some feedback on. Because I think within CMS, there's a really strong focus right now on quality measure alignment. And we're hearing that loud and clear here. And I was just thinking about all the people I want to be able to ping after this back at the agency to say, hey, we are headed in the right direction. There's more work to do and there's folks out there to partner with. I think on the community health center side in particular, Kate hit the nail on the head that if we want to bring in more safety net providers and FQHCs into our models, we've got to have quality measure sets and deviations from that measure set to make it possible for community health centers to participate. I think when you raise questions like this, even if we don't have a great answer, I think it's really helpful because it reminds us who else we need to be connecting with. I think our at the Innovation Center in particular, our relationships with HRSA are much stronger over the last year because of some of the work that we've been doing together as we think about how do we design models from the outset to allow for different types of providers and especially safety net providers to participate. And hopefully over the next year, you'll be able to see more of that progress and would love your feedback as well.
Great, Kate, Purva, thanks very much for those comments. And Purva, you and I have a few more minutes together where we'll probably come back to some of these issues too. So getting some great comments in online too and want to hear more in the room. Remember, it's questions are good, but if you have some opinions about how to prioritize or answer your question, we definitely want to hear about that as well. So let me go for a minute online where we've gotten a number of questions in already. And Rebecca, I'm going to ask for your help with this one. One question was, are there health equity measures that have been found to be meaningful to all stakeholders, payers, providers, patients, et cetera? Now, we heard a little bit about this already from Mark, Steve, from our other panelists about measures of disparities that they're working on improving in areas like diabetes care, risk factors for heart disease and stroke and things like that. So that may be one place to start, but Rebecca, let me. your
Yeah,
comments,
absolutely. No, I think those are certainly two we've heard in all the different conversations we've been having with folks. We've also heard on the pediatric side, well child checks, childhood immunizations, are other kind of priority areas to think about. We've heard a lot about, wanting to look more toward behavioral health measures as well. And so how can we kind of build an evidence base there? And then importantly, kind of throughout this, thinking about slicing the data in the same way on these measures too. So I just wanted to give another plug for that, to kind of make it interpretable in the same way across.
Right. And I should say too, we're going to have a survey at the end of this. So if you've got further thoughts, please send them in now online or in the room. We're going to have a survey after this, an opportunity for continuing contributions to these ideas. This is some really helpful input. Another comment from one of our online viewers. I would love to see exploration of cross-payer models for funding providers who are not necessarily offering traditionally billable services, especially community health workers, peer supporters, to help contribute to improving health outcomes and health equity. And I think it's fair to say, I see some nodding and agreement in the room, that part of what we mean by strengthening primary care funding isn't just funding for primary care physicians. It's for part of that broader team that can contribute to meeting people where they are, finding those who are at risk and might even have trouble coming into a physician office visit or keeping up with their medications, where we've seen a lot of evidence that community health workers, people with lived experience in the neighborhood and trust that goes along with that, can make a big difference. I wonder if any of our panelists would like to add to that. I think all of your work is reflecting this kind of broader view of what we should be paying for. And I guess I would just finally add, well, Mark, it looks like you're gonna make a comment, that it's really hard to do this under fee for service. It's much easier as part of team-based approaches where you're paying a group, a broader based practice that's working together on solving these problems.
I would 100% agree with you, Mark. I think what we often talk about is surrounding our primary care providers, in particular with care teams that can do this kind of work in a way that's meaningful. Community health workers are a great example. I would also say having a pathway toward population-based payment mechanisms is one way to do that across payers also. And I hope that we can move in that direction. That would help pay for traditionally non-payable services.
Thank you. And I think it's an interesting concept. One of the things that we are one of 3 practices across the country that's working on equity-oriented primary care, where we're looking at redesigning primary care for that of health equity. But what did we discover? What we are doing in our office in the bricks and mortar, really, yeah, it has impact, but what's out in the community? And who are the collaborative partners that we work with to achieve success? And we utilized hypertension as one of our markers of measure to see how can we get the patient from the severe hypertension down to moderate controlled hypertension, but that's what we were looking at. And we found we had to collaborate. So how does that get paid for? How is that funded? And we did that kind of part of as our value-based payment model, but we saw there's some future to this. So there is a way, there is a mechanism, but it is beyond that of just the doctor or the provider of care. It is a collaborative approach.
And just one other thing I'll add, even going beyond government-based programs, if you look at Blue Cross's covered lives, only about 20% of our commercial lives are individuals that we take the financial risk for. 80% of our covered lives, it's actually, we're essentially, we're providing administrative services for our large employers. And one of the things we're doing, we've already got some data related to things like food as medicine. We're looking at community health worker type programs as well, is being able to develop ROI models for large employers to say, hey, this isn't just the right thing to do. It actually has a demonstrable return on your overall healthcare costs. So it's something I think we tend to think a lot about in Medicare and Medicaid, but we're also trying to advance it and really put a little bit more financial rigor so that we can convince our employers that this is the right way to go as well.
Great. Well, I appreciate all those comments. It reminds me of something else here too, which is that, while we've talked about specific data steps and measure alignment steps and broadening and strengthening the payment system alignment across payers with the key goals here, there's a lot of experience with these models around the state, and a lot of people who certainly here today are having not a lot of willingness to share it. It doesn't seem like the view here is that finding solutions to these problems is something that's just proprietary to one health plan or one practice. So I think one other complementary step that we're going to try to highlight in the STC work going forward is, okay, if we do identify a few priority areas, like getting those severe hypertensives to better control or hopefully full control, can we share best practices and steps that are people are using, that are undertaking, using the data, using the payment changes, using measure alignment to help get there. That's the spirit that we're trying to collect here. Okay, I'm gonna go to, we've got one in the room, and then I go back to online. So lots of good discussions.
Hey, thanks, everybody. Jeannie Kamovas. I'm with WellCare North Carolina. I'm the chief medical officer there and a family physician. So just a couple of comments. One is we've talked a lot about quality alignment. I'll get there in a second, but other opportunities for alignment. We spend a lot of time on our Medicaid calls talking about attribution, how patients get attached to a quality measure or how they get attached to a provider for the purposes of value-based payment. I think there's tremendous opportunity for us to align on that methodology across payers so that the providers understand how they're being evaluated, because it's as much about who's in the denominator of a measure as it is about how you perform. But getting back to quality, I think where Dr. Smith was going, really critical, we prioritize getting quality data into and out of the HIE. I know we payers spend a lot of time going to practices, collecting files or going and doing chart reviews. It's a big administrative burden for us. It's painful for the providers, and the sooner that we can have that single repository, the better we'll be. And then my final point on the quality is I've been sitting in on some, it's the Clinical Quality Measurement Collaborative, which is, I believe, a sort of federal collaborative around creating core quality measure sets. They've done a really good job of pulling together some core measure sets in specific specialties and also cross-cutting measures. And they're, I think it's fantastic work. And to the extent that we can, familiarize ourselves with that and try to take advantage of that. I was in a meeting earlier today with our national team talking about value-based payment and quality measures, and everybody's talking about what can we take from the CQMC work. So I think there's huge opportunity.
Yeah, it's a great point about the national collaboratives and work to develop standard measures that has gone on. Jenny, I also appreciate the other comments about, okay, well, it's one thing to have standard measures. It's another thing for those to be like automatically able to be captured reliably, securely, accurately, and completely from electronic records. I mean, that was the point of electronic record adoptions to support care improvement activities like this. Mark mentioned you getting the technical weeds with FHIR standards and so-called US CDI plus common data sets. But there is a lot of work going on in that area nationally that hopefully we can leverage. So when we talk about, okay, it's gonna be the same data and the same measures, that's not where we should stop. It's like, are there quick, reliable, easy ways to construct those, including, as you said, not just the numerators, but the denominators and the attributed positions as well. So great point. So let me go back online for one more. We're getting a lot of great questions in. This is a question, not a comment. And Rebecca, I'll go to you to start on this one. Will the North Carolina State Transformation Collaborative include the most important stakeholders, community members, patients, people living with chronic diseases or catastrophic illnesses? And I know a lot of your convening prior to this STC has involved support, including the support from foundations here in North Carolina, like the KB Reynolds Trust, to make sure those voices are not only heard, but empowered in bringing these efforts together.
Yeah, no, it's a great question, and a super important perspective that we can't do this work without community members and families and caregivers. Two thoughts here, and I'll pick up on one of the threads that you were just mentioning, Mark. One is certainly, I think there's an opportunity when we talk about quality measurement and health equity data. It's about getting the technical pieces right, but then how do we actually translate that into coordinated action at a community level to really make a difference? And so I think that's going to be a critical component of this work. It's not just getting the technical pieces right. We are fortunate to have funding at Duke-Margolis from foundations like KP Reynolds, like you mentioned, and trying to do some really concerted efforts around how do we generate evidence-based recommendations for centering equity and all of this work. So doing a lot of community engagement through that work that's getting ready to start.
Yeah, so I guess to take this question to the next level, so the question, the answer to will the SCC, I guess I should say it's only fair to say at this point, try to include these perspectives. Yes, that's absolutely the intent. And so what we want to hear about is, okay, what's the best way to do that? We've got some ideas based on the kinds of participatory collaboration we've done already, but we're going to step this up. We've got some more resources, some more commitment, some more engagement behind it at both the state and federal level. How do we do that right? We'd really like to hear more. It is a super important question. Okay, I've got one more from online, and I think we may be about out of time, but this is important since it's come up a number of times, starting actually Secretary Kinsley with you. Behavioral health, value-based approaches need more unified efforts across at least the Medicaid plans. There are too many Medicaid plan approaches for success, especially with small behavioral health provider agencies with small numbers by plan. Now, I didn't actually mean to put you personally on the spot for this question, but since you're here, and fortunately we've got like Shannon right next to you to make sure that this is.
What I'll do is I'll give an answer, which will give Shannon enough time to write a limerick. And then we'll tag team it. I think that there's a kind of foundational issue here, which is that our behavioral health providers have really been left behind on a lot of the long-term investments that we have needed to make,
including electronic data.
Exactly. I mean, I was working at the Office of the National Coordinator for Health IT at HHS when, it was like, well, we don't need to do meaningful use support for folks that are psychiatrists because they're specialists, they have plenty of money. That was a little bit of the attitude, which was wrong. And so, this has been a space where I think we have been making a lot of investments and trying to help just even get that infrastructure to a place where it's easy. And yet we still know that, if we were to kind of pull the trigger on requiring connectivity to the HIE, which would in turn require EHRs, we would have a whole swath of individuals that work in the behavioral health space just completely opt out and retire and leave the field. And so, one thing is I'm happy to thank all of my payer friends, us included, who have really tripled down on our investment in behavioral health. I think during COVID in particular, we saw intrinsically that there is no health without behavioral health, and we needed to make that easy, and we needed to make it easier for our patients, beneficiaries to take advantage of that in every way possible. So I hope that we will continue to keep the gates on that wide open. I mean, it is a tragedy when we look at parity concepts for behavioral health between physical health. Is a tragedy when we look at network adequacy, folks. 1 in 5 people have a behavioral health need in a given year. Like, the current networks are just woefully inefficient and inadequate. And so I just am glad that folks are leaning in that direction. We have much more to do. So I say that only to put the baseline, which is that it's really hard to then drive a whole lot of accountability onto a cadre of individuals who are woefully under-resourced and have been for a long time. I'll say this last thing and pass it to Shannon, which is, of course, here in North Carolina, there's nothing more foundational that we could do to support this group of individuals than would be to expand Medicaid. I mean, when you are, when 30 to 40+% of the people walking through your front door don't have a way to pay, as a business, you're not going to stay in business. And I think we are very close to that. It's going to take our collective efforts and shoulders to push that over the finish line, but that gives us an opportunity to really finally transform. So I'm looking forward to that.
I'll add on just 3 things from the Medicaid perspective. One is, I mentioned in my comments, the Collaborative Care Consortium. this was a multi-payer group. So we got together and said, how can we get care to mild to moderate behavioral health needs out into the primary care practices, make our workforce issues work better by making sure the right folks were getting to the psychiatrists that need psychiatrists. And that's been huge, so all the payers kind of band together, say, yes, we're going to prioritize this model. Yes, we're going to pay for it. So practices aren't trying to figure out which patient gets which service. So we did that work, and now we've got to, continue to implement it. I think the other thing that's really interesting is when you look at our standard plan launch, so we're a year and a half live from managed Medicaid, which is about 1.5 million plus of our beneficiaries, our members. And we looked at the CAP survey, so their beneficiary experience and then provider experience. One of the things that was really remarkable to me on the provider survey, where we went out to the providers to say, how's this transition going? What's better? What's worse than Medicaid Direct or Medicaid prior to managed care launch? What has gotten better is actually access to behavioral health, prescribers and other types of providers. And so that is really exciting because overall it does feel like there's a lot of heaviness and hard work in the behavioral health space. And then the last thing I'll say is that we clearly need to revisit how we pay behavioral health providers, and Medicaid specifically need to do some work on our rates and update things and kind of get caught up.
And integrate with this stronger primary care, as we've just been talking about. So some special challenges in behavioral health, but as you can hear, a lot of commitment to try to work on that too. For those of you who have some experience and further thoughts about behavioral health in particular, there's a huge amount of unmet need now, lots of opportunities to deliver care more efficiently at higher value. It does need or would benefit from digital supports, as well as making sure we're taking advantage of innovative technologies like telehealth. So we'd like to build that into the work of the STC as well. So please do send comments on that topic too. And as I wrap this up, this has been a great sort of room-wide and online discussion with all of you. This is just the first of more to come. You will have an opportunity at the end of this event to submit some further comments via survey. And we definitely want to hear from you. You know where to find us at Duke-Margolis. So right now, I'd like to shift this local conversation back up nationally and ask Purva Rawal to come up and join me. While Purva is coming up, I'd like to introduce her. She's the Chief Strategy Officer at the Center for, sure, have a seat right there. She's the Chief Strategy Officer at the Center for Medicare and Medicaid Innovation, part of the senior leadership team there. And, having had the opportunity to work with her on these SDC issues, on a whole host of other issues around care transformation, she really does manage to take a very broad perspective of not just what's going on in her part of CMS, important as that is, but coordinating efforts around advancing care reform across the agency and bringing in perspectives from other parts of the federal government. And you've been on the road some too, I think, right?
Yeah, it's been nice to get out and actually hear from people.
Yeah. And so here you are in North Carolina, not our best weather day, but glad to have you here. That's right. It could be worse, right? All right. So you've heard a lot about what the SDC here is trying to do. You've heard about some of the specific strategic goals and maybe concrete actions to get there, like quality measure alignment, aligned priority measures related to improving equity, key data sharing, sharing best practices, technical assistance, and some trying to work in steps to advance the behavioral health priority that really matters to North Carolinians from the Secretary on down. How does this match up with what you're seeing nationally and the national goals related to CMS, strategic transformation, STC efforts more broadly, et cetera?
Well, I guess I'm relieved because, and maybe great minds think alike, because I'll talk a little bit about our strategic refresh at the Innovation Center. And when I was learning more about what the STCs in North Carolina or the STC in North Carolina is embarking on, it really struck me that there is an amazing level of alignment and synergy across what we're thinking and what we've put forward over the last year and a half and where we're headed. And hopefully we're all headed together. I think Secretary Kinsley summed it up nicely by saying, we want to focus our effort on the things that are important. And so the more that we are all kind of aligned on priorities, I think it allows us all to focus our energy and resources, which of course are always more limited than we want them to be. So about a year and a half ago, the center, CMMI, embarked on a strategic refresh. We took stock of over 50 models that we've launched in the first decade, really tried to understand what lessons we learned from those 50+ model launches. We talked to a number of internal leaders at CMS, external leaders, as you know, like Mark, to really think about and chart our path forward for the next decade. That how do we, as the Innovation Center, of course, launch new national models, but how do we also interact differently with states and state efforts, and how do we embed ourselves in those as well to drive greater system transformation? And out of that effort really came 5 strategic objectives. And I'm going to walk through them because they align so well with a lot of the discussion today. And the first is really to drive accountable care. We want to have 100% of our beneficiaries in Medicare fee-for-service beneficiaries, the vast majority of our Medicaid beneficiaries in accountable care relationships by 2030. And that means we're really focused on advanced primary care models and ACO models as the mechanisms to be able to deliver that accountable care. And I know that is top of mind here in North Carolina. This is a very innovative state with a long history of innovation in primary care. And so I'm hoping that that's a place where your input and your feedback and the work that you're doing on the ground, your priorities can help inform our work and shape our future model development.
And by the way, for those of you who think that, well, 2030, that sounds a long way off. You put in some numbers. Well,
did.
first of all, it's not that far off. And second, you put in some numbers that are a big level beyond where we are today in terms of coordinated whole person care for Medicare and Medicaid beneficiaries and others in our health system.
That's right. Yep.
Much sooner than.
In November of this past year, we released a 1-year report on our strategy and where we've been on implementation over the last year and where we're headed next. And as part of that, we've set some metrics across each of these 5 objectives, including our accountable care metrics, to get to 100% by 2030. So I think we have a 2025 goal of, don't quote me on this, but like 60% to help us get there. And models like our ACO REACH model, our primary care first model that's, you know, operating across the country in the future, advanced primary care model, those are all going to help us get there, along with our work with the shared savings program.
And you said 4 other areas.
So the second is advancing health equity, which we heard a lot about today. I can talk more about that if we want, but really data collection. It starts with data collection. We have some required self-reported demographic data collection efforts that we're launching through our models. We're already getting early feedback from some of our model participants about what's working, what isn't. And that's obviously an area of alignment with everybody here. Our third objective is supporting innovation. A lot of our data objectives here, so data access, standardization, some of those objectives sit there. And I know obviously data and quality measurement were the 2 things that we heard the most about today. We also are thinking about quality measure alignment across CMS as part of that effort, and also thinking about patient-reported outcome measures, which also came up today. And I know that that's part of what you're talking about in North Carolina. So not only do we want to get alignment across programs and across payers, but we also at the Innovation Center want to be thinking with an eye towards where should we be pushing next on quality measurement? What can we be testing in our models to get to more meaningful measurement over time and inform the broader Medicare and Medicaid programs? The fourth is addressing affordability, which I know that's a big overall goal in North Carolina with a lot of the strategies feeding into reducing cost for families. And the fifth is partnering to achieve system transformation. And the STCs are really being the work that Kate's leading is really important for us to be getting out there, to be hearing from folks, and hopefully be joining the table. There, you guys are already have a number of efforts underway in North Carolina. I really view our role as us coming to the table to hear from you and to see how our work can help accelerate the efforts here.
Okay, so that's a lot. And I would just say, add to that, and you talked about this as being an innovation center-led effort, that strategic refresh that you published included a lot of perspectives from not just the Innovation Center, but efforts to kind of align across all of CMS.
Yeah, so I can talk a little bit, I can give a couple examples of some concrete ways that we're trying to get that kind of alignment. I think Kate did a great job earlier of talking about how we're trying to align on quality measurement specifically. And again, yesterday's paper, I was so glad it came out at 5 o'clock yesterday. I was like, thank God. So what we released was a set of universal, what we're calling universal foundation set, where we want to be able to at least get alignment across CMS programs on a set of quality measures. And then at the Innovation Center, our goal is to align with that measure set wherever possible. Obviously, there might be deviations if we're testing something in a specific population, but also places where, again, we can get to a more parsimonious measure set and really be pushing the envelope on patient-reported outcome measures. But that's a across CMS, initiative. We're working with our colleagues at HRSA again. I think the other place, another example I would point to where we're working again outside of the Innovation Center, working with our colleagues, is our ACO vision and our ACO strategy, where I think for the first time, CMS was really able to put a Medicare ACO vision strategy together. We published that last April, and you started to see some of those changes come out in the Medicare physician fee schedule this year. And hopefully over this next year, you'll see greater alignment between CMMI models and the share and the National Permanent Shared Savings Program. I'll just give you one example of why that kind of alignment is important, because as we're testing innovations, and hopefully some of those in North Carolina will be part of some of that testing and some of those innovations, we have to figure out what works and what doesn't. And if something doesn't work, we don't keep going there. But if something is working, we want to find a way to scale it more broadly into the Medicare and Medicaid programs. And so that's what we're able to do the more that we're aligned across the agency and with the Center for Medicare.
And you talked about alignment across CMS and some very important steps. And again, good timing with that New England Journal article too. If
We've been
people
waiting
can-
for it.
So, and you talk about your fifth priority being system change and how important partnership is for that. So alignment across CMS, that's a very important and challenging step, but you're aiming for much broader alignment than that, including through the STC. And I think if people can stand, we have like one more slide. If people can stand, are putting it up. See a thumbs up. So you mentioned that. So this is a list of. Well, that's us. This is a nice picture of you too. This is a list of CMS alignment efforts that some of what you've referred to. So the Medicare Shared Savings Programs, that's the main statutory kind of workhorse ACO program, which is now increasingly aligned with pilots at CMMI that are filling in at the high end, the very advanced ACO reach, and filling in for the providers, especially the smaller, more rural ones, some of the smaller safety net organizations that had trouble getting into the program so far. You've talked about quality measure alignment. You've talked about some of the steps that Medicaid is taking to make it easier to pay for so-called in lieu of services and so on. One of the things that we're seeing coming out of this is the opportunity to make it clear to everyone in North Carolina who also cares about these issues that, you know, having formerly been administrator at CMS, this is not an agency that turns on a dime. I don't think you'd want that anyway, and Congress is never going to allow it. There are a whole bunch of regulatory processes and authorities that CMS has to operate within. But these are, thanks to efforts by CMS, these are getting to be more predictable and ones that you can anticipate. So for example, CMS laid out its next priorities, which very much align with what we've talked about here for supporting more aligned quality measures across programs, for building out steps to strengthen primary care and help provide a better on-ramp in its regulations this past year for healthcare organizations. And that's a process that we know is going to happen again this year. There's going to be a comment process. There are going to be further steps that permit alignment. There are going to be further steps on the quality measurement approach. One of the things that we're hoping to do as part of this STC, and where your involvement and you know, CMS actually being here is very helpful, is making sure that people know about that. So as we make progress on these particular priority areas, CMS may not be able to align right here, right now on what some of the things that the state would like to do collectively, but there is a process that hopefully can become clearer. What do you think about that?
Yeah, I mean, I think the more clarity that we can give, and I think it's always tricky, Mark, as you know, running CMS, that there's a lot often that's happening, but that we can't talk about publicly. And so it's always towing that line between how do we get input from interested parties, and how do we signal where we're going? And it's sort of this kind of little bit of art more than a science I'm finding, but I completely agree. I think there's a regular cadence of rulemaking and things that happen every single year that we can use to, you know, hopefully continue to send signals about where we are headed and what those points of input are. I think what's difficult sometimes about innovation center models, and I know there's some former CMIers in the audience here who can, who can back me up on this, but we're often disruptors. We're not working through the regular cycle and the regular rulemaking cycle, but that again, within CMS, even one of the things the Innovation Center is really trying to do is understand and make sure that when we're thinking about models and launches and working with states, that we're aware of what the cadence of activities is at a state level, what the cadence is within the agency and other parts of the federal government, so that that disruption is, in the context of all, everybody's goals.
And what we'll hopefully be able to do as part of this process of your commitment to alignment and everyone working together towards these common goals is maybe flesh out that those rules that are coming. People here I know have better things to do than keep track of every single CMS rulemaking calendar, but we can hopefully make it easier for them and slot in the steps that the state is thinking about taking and what time frame that relate to this, and slot in the steps that our private sector health plan partners and others are.
I think what was really helpful is like hearing about the strategies and the priority areas in North Carolina. And that's why if, the STCs can be a blueprint for how this can happen in other states, I think this could be really powerful, because what you've done is you've laid out 4 areas. And my mind was going to, well, here are the things that are coming or that we could be doing together. And so what it allows us to do is, again, you don't need to boil the ocean. You don't need to about every rule, but for the priorities that the state has outlined here, the collaborative has outlined, where are those kind of, entry points for you all as well, and those points of connection with the agency?
Well, we really appreciate the concrete steps that you're taking so that this isn't just a strategy, but back to the theme for today. Okay, what are we actually going to do differently that will make a difference? And that seems like it's going to apply to opportunities for the collaborators here to work with CMS and other federal agencies. So Purva, thanks for taking the time. Don't go anywhere, because I just have 2 more minutes of comments for all of you. This has been a great discussion from my standpoint, but this is the start, not the end. We've got an initial roadmap. We've gotten some really useful, concrete, specific feedback and critiques. And we want to hear more of those to make sure we're making the most of this opportunity to work together and make the most of the opportunity to bring in federal support. And as Purva was mentioning, experiences from other states. We are one of the 4 STC states, but there will be other relevant experiences. And hopefully what we're doing here is going to be relevant to other places as well. So it does seem like some real opportunities to accelerate progress. And to make sure we keep taking advantage of these opportunities, we want to hear more. We want to stay in touch. So there will be a post-launch survey that you all can take right now. Actually, just use the QR code. Again, this is probably the most QR codes I've had in a meeting for a while, but we'd like to hear from you on that. We're going to continue the meetings of the State Transformation Collaborative. Some of it is going to be down in those technical weeds with things like FHIR and USCDI, but we're also going to try to make sure there is transparency and lots of opportunities for input to make not just about the strategic directions, but make sure we're getting these concrete steps right. So thank you for making this possible. Thanks in advance for participating in future convenings, both virtual and in person. It is great to see so many people back together in this room. Where we used to have a lot of our North Carolina events, but it's been 3 years plus. So great to see everyone here today, and more to come. I do want to give a special thanks to everyone from the state who has made this possible. This is a lot of work on top of a whole lot of implementation efforts, and it's a sign of just how much it matters to DHHS that we do this together and we do it effectively. And I also want to give thanks to our out-of-town guests from CMS. Hope you like in North Carolina so far. We hope to have you back again soon as this work continues. And a special thanks to all of you. You're making this possible. It's your ideas and your insights that we're trying to bring together and build on. And finally, a thanks to the team at Duke-Margolis for organizing and hosting this event, Rebecca and the rest of the team. This is a true collaborative. Thank you for making it possible, and we're looking forward to continue to work together on care transformation here in North Carolina. It matters so much. Take care and have a good rest of the day.